Sorry, you
Piyush.
can.
Piyush.
You can start,
Help
ma'am.
me.
Yes. Warm welcome to all delegates and our most eminent and well-known gynecologist, Dr. Amol Lunkar sir, and Dr. Ramesh Gaikwad sir, who is today's speaker. So I think today we are going to have a more to know about infertility as well as recurrent pregnancy loss, and we are getting all this knowledge from a very eminent speakers. So we are very lucky to have our speaker, Dr. Amol Lunkar sir. So welcome, sir. And Dr. Rajan Sancheti, welcome. Still, many people are joining. We will start with the session because it is already 2:05, more than 2:05. So I will request our President, Dr. B.L. Deshmukh sir, to introduce, give introduction.
Good afternoon, everyone. I welcome you all for this webinar on infertility. In human, infertility is the inability to become pregnant after or trying to get pregnant with frequent unprotected sex for at least a year with no success. Sterility may be primary or secondary. Secondary infertility is the inability to become pregnant or to carry a baby to term after previous giving birth to a baby. There may be male factor or female factor. Infertility may be unexplained, or you can say infertility is that idiopathic in sense that its cause remains unknown. And to deal with, we have Dr. Amol Lunkar and Dr. Gaikwad with us. They will explain regarding this infertility.
Thank you, sir. Sir, first lecture we will start with Dr. Amol Lunkar sir, and he'll be speaking on recurrent pregnancy loss. This is a short introduction. Actually, it's just one-page introduction, but he's really, if we start giving his introduction in details, I think 1 hour will be required, isn't it, sir? So Dr. Amol Lunkar is a MD obstetric gynec from AIMS. He's a DNB, OBGY, and MICOG, MNMS, DGE, Germany, FRART, USA, Diploma in Bioethics and Reproductive Law, Harvard, Chief IVF Specialist of Indira IVF Center, founder member of Gynec Endocrine Society of India. So he has awarded prestigious Indumati Zaveri Prize for Best Research Paper in 2010 by All India Congress of Obstetric and Gynecological Society. That is in AICOG, awarded the Suli Rudra Sinha Prize for the Best Advanced Gynec Endoscopy Surgery by Federation of Obstetrics and Gynecological Society of India in 2010, that is FOXY, and awarded the best oral paper presentation at the National Conference on Gynec Endocrinology in 2011, held at New Delhi in April 2011. Author and co-author for 28 national and international research papers and chapters. He has removed a 7 kg ovarian tumor laparoscopically in April 2012, which was uploaded by various national TV channels and newspapers. He has done 12,500 plus embryo transfers with 9,000 plus successful IVF pregnancies. He is a winner of Hall of Fame IVF Specialist of Western India at All India Fertility Awards in 2019 at New Delhi. He has been awarded Most Inspiring Gynecologist of Western India 2018 by Economic Times. He has been awarded the Pune Times Man of the Year 2017-2018 by Times of India, and the Pune's Most Powerful Achiever 2016-17 by Femina magazine. Yes, featured in hundreds of health talk shows on national and regional TV channels and radio programs. So, over to Dr. Amol sir. Sir, please, you can start your lecture on recurrent pregnancy loss.
Thank you, madam, for your kind words. Thank you, Dr. Deshmukh, for giving us this opportunity. I would like to thank IMA Pune for this novel idea of having afternoon knowledge sharing with MMC points. So, as Dr. Alka Shirsagar has introduced me, and I will be speaking on recurrent pregnancy loss. It will be a mixture of some theory and few practical cases. So, as we all know, it in our day-to-day practice, we face patients with recurrent pregnancy loss, and it is those who have regularly seen such patients in your practice, you will definitely agree with me that it is quite a depressing or a distressing situation for the couples, wherein when the whole world says give up, hope whispers, try it one more time. So having a pregnancy and not able to have a live baby in the hand is one of the quite distressing or depressing situation for the couple. I will cover this topic under the following heading. Let us look what is the definition, its prevalence and etiology. Let us have a look at certain interesting cases or practical cases of recurrent pregnancy loss, and then how we evaluate such a couple and how we treat them. So we all know the classical definition of recurrent pregnancy loss was 3 or more consecutive pregnancy losses prior to 20 weeks of gestation, and biochemical pregnancies were not included in this. But the more practical and the more current one which is followed is occurrence of 2 or more failed clinical pregnancies. So we do not wait till the third pregnancy now. We start evaluating them, start helping them after the second loss itself. The overall incidence of recurrent pregnancy loss is 1 to 2% of all couples, and it can be classified into primary recurrent pregnancy loss, secondary, and tertiary, depending on whether there was a previous viable infant or not, a previous successful pregnancy or not. Overall, if you see, the chances of first pregnancy having a pregnancy loss is around 12 to 13%. After first miscarriage, it is almost similar, say 14 to 20%. But after the second miscarriage, the chances of subsequent miscarriage in almost, you can say, is 1.5 times higher, that is around 25 to 30%. And after third miscarriage, having a subsequent miscarriage is almost 33%. But the silver line of this dark cloud is that even after 3 miscarriages, the subsequent pregnancy being healthy is as high as 65 to 70%. And after third miscarriage, or you can say after fourth miscarriage, also the overall incidence remains the same. So it does not increase substantially after the third miscarriage. Hence, we start investigating a couple after 2 consecutive miscarriage itself. So we can label a couple as having RPL or recurrent pregnancy loss if there are 2 consecutive miscarriages, and we should start evaluating and helping such couples. We know that the etiology of recurrent pregnancy loss can be varied, right from anatomical causes to endocrinological causes to immunological causes to genetic causes to microbiological causes, and still a large chunk remains idiopathic. And we know that many causes of recurrent pregnancy loss and infertility go hand in hand, and that is why we as IVF specialists or infertility specialists get to see many patients of recurrent pregnancy loss in our day-to-day practice. Because if you see, the many causes of recurrent pregnancy loss and infertility overlap, like the uterine causes, genetic causes, the male factor, ovarian factors like premature ovarian aging, endometriosis. These can result into recurrent pregnancy loss, can also result into infertility. And many times patients with recurrent pregnancy loss do land up with secondary infertility also. Also causes like tubal factor infertility or tubal factor causing recurrent pregnancy loss have common, you can say, etiology for RPL and infertility. Similarly, cervical factor, immunological factor, endocrinological factors, you can see, can cause RPL as well as causing infertility. Of course, there are certain unique causes for infertility and RPL as shown hereby. Let us see some interesting cases. These are actual practical cases seen by me in my practice. This case one is presented to me in 2017. She was 32-year-old then. She had a history of 8 previous abortions. So right from 2010 to 2017, she had consecutive miscarriages at various times of pregnancies. First, 2 were spontaneous abortion at 6 to 7 weeks. Both times sonography was not done. Her third pregnancy was a abortion at 10 weeks. The sonography had documented fetal heart activity at 8 weeks itself, but at 10 weeks there was a missed abortion. DNC was done. Yeah, even a subsequent karyotype of husband and wife was done, which was normal. Then in October 2012, she again spontaneous conception was there. She had taken preconceptional folic acid. She had taken preconceptional aspirin in this pregnancy. Pregnancy continued well till 12 weeks, and then at 12 weeks she had missed abortion and a DNC was done. In 2014, it was unfortunately a right ectopic pregnancy, which was medically managed by methotrexate. And 6 months later, a hysterosalpingogram was done, and a normal uterus with normal tubes were seen. So, first 4 abortions, DNC done twice, then an ectopic pregnancy. Her 6th pregnancy was in 2015, January, and it was a spontaneous conception. She had taken preconceptional folic acid, aspirin, and this time she also took low molecular weight heparin. But again, at 12 weeks, it was a missed abortion. A DNC was done. Her 7th pregnancy went very well, and she had it was a spontaneous conception. She had taken folic acid, aspirin, low molecular weight heparin. 14 weeks, she underwent a cervical encerclage. Her double marker was normal. Her anomaly scan was normal, but this time she had painless dilatation of cervix followed by PPROM and delivered at 22 weeks a 550-gram female baby fresh stillbirth. So you can see this couple is having various reasons of recurrent pregnancy loss. And she is going from one complication to another. And her 8th pregnancy was in 2017, again spontaneous abortion at 8 weeks. So they have had several, you can say, pregnancy losses and various reasons of pregnancy losses in different pregnancies. So such certain, you can say, unfortunate couples are seen in our practice who have various complications in various pregnancies, and that is hindering them to achieve a live birth or a proper healthy pregnancy in the hand. So when she came to us, this couple came to us, we did her routine investigations. Her blood group was Rhb positive. Hemoglobin was normal, GTT was normal, her TSH was in normal range, her AMH or anti-Malarian hormone levels were normal. Histoscopy was done, which was within normal limits, but the cervix was patulous. You can see the picture of histoscopy on the right of your screen. Her rubella IgG-IgM showed immune. The patient was immune for rubella. Husband had a normal semen analysis and a normal sperm DNA fragmentation index. So these were the investigations which we did. We also investigated the couple for acquired and hereditary thrombophilias. So lupus anticoagulant was done, anticardiolipin antibodies IgG, IgM were done, beta-2 glycoprotein IgG, IgM was done, and all were negative. Hereditary thrombophilia, we checked for factor V Leiden mutation, protein C proteinase deficiency, antithrombin 3 deficiency, and APCR resistance or protein C resistance was also checked, and almost all these reports were almost within normal limits except low antithrombin, which is non-specific. So the thrombophilia screen also did not lead to any positive, you can say, etiological factor. What we did is, because she had a failed cervical encerclage in her 7th pregnancy, that is why we planned her for a laparoscopic abdominal encerclage. And this laparoscopic abdominal encerclage was done with a Marcelin tape at the level of internal os. You can see the video here. There were few adhesions because might be because of the previous pelvic inflammatory disease, or maybe due to repeated DNC, she had some adnexitis or salpingitis, which also resulted into an ectopic pregnancy. So these adhesions were removed. So adhesiolysis was done by sharp dissection with sharp scissors. And after the adhesiolysis, the UV fold or the utrovesical fold was dissected. You can see here the UV fold being dissected now. And after doing sharp dissection of the utrovesical fold, the bladder was pushed away. And at the level of internal os, Marcelin tape was passed. So this Marcelin tape was tied anteriorly. Now this Marcelin tape is going to cause fibrosis at the level of internal os and thus increase the cervical strength. So because of a failed previous cervical encerclage, a plan for laparoscopic abdominal encerclage was done. So you can see the Marcelin tape now being passed on the right side from it's a double needle tape, and bilaterally it is passed, and the Marcelin tape is then tied anteriorly, and this knot is secured, and the UV fold is then closed. This is how we do laparoscopic abdominal encerclage, especially in patients with failed vaginal or failed cervical encerclage. So her previous cervical encerclage had failed, and so laparoscopic abdominal encerclage was done. And post laparoscopic abdominal encerclage, she was given oral contraceptive pills for 1 month, and then she was told to start on preconceptional folic acid aspirin for 3 months. She conceived naturally 3 months after the surgery. Immediately she was started on low molecular weight heparin once daily 40 mg. She was started on immunoglobulins. Her pregnancy went well. Non-invasive prenatal testing was done at 12 weeks, what we say as NIPT, to rule out any aneuploidies, to rule out any Down syndrome or any chromosomal aberration. So NIPT was done at 12 weeks, which was within normal limits. Her high-risk pregnancy care was continued. She had basically a live birth at 36 weeks with a elective LSCS, and a 2.5 kg female child was born. So elective LSCS was done because after a laparoscopic abdominal encerclage, vaginal delivery is not allowed. So we have to do elective LSCS once we give abdominal encerclage. Now let us go to case number 2. 32-year-old presented to us in 2021, secondary infertility with recurrent pregnancy loss, previous to abortions, married for 7 years, and DNC was done twice for this. She had then secondary infertility. So in 2015 and 16, she had abortions, and then after 2000, from January 2017, she had no pregnancies then. So secondary infertility with recurrent pregnancy loss. She had a history of ovulation induction done 3 times. IUI 2 cycles were done, which failed. So what investigations we did was routine preconceptional investigation. We could see her AMH was high, 9.06. So she was having PCOD. Even her sonography, you can see, showed antral follicle count was almost bilateral. If we add, it was almost 26. So it was clearly she was having PCOD. And rest of the investigations were all within normal limits. So a case of secondary infertility with history of prior recurrent pregnancy loss with PCOD, that was her picture on initial investigation. We did karyotype of husband and wife, and you can see the karyotype report. The husband karyotype came out to be 46XY, translocation of 15 and 17 chromosome. So husband had translocation. The break points of this translocation could not be determined in the first karyotype. Of course, subsequent culture, we could determine the break points because it was important for us to find the break points to assess the embryos then. So husband on karyotype was found to have a translocation between chromosome 5 and 17, and the wife's karyotype also had some variation, a large heterochromatin region in the short arm of chromosome 21. So basically now we had a case of secondary infertility with recurrent pregnancy losses, with PCOD, with husband and wife karyotype having abnormalities, husband having translocation and wife having a large heterochromatin region in short arm of chromosome 21. So this patient was planned for pre-genetic testing. So IVF was done for this patient, pre-genetic testing was done, and genetically normal embryos were found out, and genetically normal embryos were implanted back into the uterus to achieve a healthy pregnancy. So we gave her controlled ovarian hyperstimulation to form multiple eggs. These eggs were fused with husband's sperm to form multiple embryos. These embryos were then checked genetically, what is known as pre-genetic testing. And in this patient, we had to do pre-genetic testing for structural rearrangement and pre-genetic testing for aneuploidy, both. And on doing pre-genetic testing, these were her embryos which were formed. You can see ICSI was done along with the use of microfluidics as sperm sorting technique. And in March 21, her stimulation was started. We used recombinant FSH by the brand name of Folisurge for 11 days. Cetrotide, that is cetrorelix, was added for 6 days. Trigger was given with decapeptyl because she was a PCOD patient. And on 7th April, her eggs were retrieved. We got 30 mature eggs to give 4 good blastocysts. And these embryos were genetically checked to find out 2 genetically normal embryos. Here you can see the genetic report. The pre-implantation genetic testing for structural rearrangement was done, or the old terminology was PGD. So PGD was done. 2 genetically normal euploid embryos were found, and these 2 embryos were transferred to achieve a pregnancy. This was her beta HCG report. So here you can see a patient with secondary infertility, with recurrent pregnancy loss, with karyotypic abnormalities, and was very well managed with IV, that is ICSI, with pre-genetic testing, and to give a healthy pregnancy to this couple. So after looking at these 2 interesting cases, let us see how we evaluate a couple with recurrent pregnancy loss or RPL. Evaluation is most important, and evaluation always starts with a good history. And after proper history, complete examination of the couple, and then with certain investigations. And these investigations will be general investigations in the start, which will be same as all preconceptional investigations which we do for any couple who is planning to go for pregnancy. And then there would be certain specific investigation to rule out any specific cause of RPL. And what are the specific causes of RPL we want to rule out? First, we have to rule out anatomical factors. Both congenital and acquired anatomical factors are known to cause recurrent pregnancy losses. Congenital anatomical factors like septate uterus, diadelphys uterus, bicornuate uterus, unicornuate uterus, or an arcuate uterus, all are known to result into pregnancy losses. Acquired anatomical defects like Asherman syndrome, fibroid, endometrial polyp, or a space occupying lesion in the endometrial cavity, or cervical incompetence, all these can cause recurrent pregnancy loss. We have to do a proper 2D, 3D ultrasound. So simultaneous transvaginal, transabdominal, 2D and 3D ultrasound is going to tell us everything about the anatomical factors in most of our patients. Here you can see a very good 3D scan, a good normal uterus with a triangular uterine endometrial cavity and a pear-shaped uterus with a normal myometrial wall. So this is a normal uterus on a 3D scan transvaginally. So we have to see not only the outer serosal lining, but also the endometrial, you can say endometrial cavity, and the shape of the endometrial cavity, and the relationship of the fundus and the serosa. So all this has to be seen. Here you can see on 3D scan arcuate uterus, you can see a fundal dip in the endometrial cavity. So then you can see a septate uterus, a complete septum. So you can see that the serosa is uniform. So this picture C, you can see the serosa is uniform. There is no dip, while the cavity is divided into 2 halves by a thick, broad septum. Similarly, the picture D, we can see a bicornuate uterus. The serosa is also dipping, and there are 2 separate cavities. So So these various anatomical defects can be easily made out on a good transvaginal 2D, 3D scan. And there can be acquired defects like fibroid uterus or adenomyosis or intrauterine adhesion or Asherman syndrome or an endometrial polyp, which can also result into recurrent pregnancy losses. So our evaluation should rule out each cause separately. So good 2D, 3D transvaginal scan, and if required even a transabdominal scan, will help us to rule out almost all anatomical defects. And these are the various anatomical defects which we are talking about. Again, cervical incompetency is one very important anatomical defect. We saw our first case, or case one, which we saw, had cervical incompetence, which resulted in her loss of pregnancy, and then a laparoscopic abdominal encerclage was done. So we have to rule out anatomical factors and treat any anatomical factors if it is present. So the various, you can say, guidelines clearly recommend correction of acquired abnormalities of the uterine cavities. Do consider surgical correction of uterine septae or uterine cavity distorting leiomyoma or fibroids. Uterine cavity distorting adhesions or polyp have to be surgically corrected. Again, here you can see a very nice video of a complete septum with a complete uterine septum, cervical septum, and also vaginal septum. So this patient again had recurrent pregnancy losses. Previous 3 losses were there, and on doing a transvaginal 2D, 3D scan, we could clearly make out a complete. Here you can see on histoscopy, we have entered into the left side of the cavity, left half of the cavity. We are coming out now, and we would then go to the other side of the cavity. So we could find a complete uterine septum along with a cervical septum dividing the cervix into the two, and also the vaginal septum dividing the vagina into two halves. And the septum being an avascular structure, any pregnancy which gets implanted on this septum is not going to grow properly and is going to get, here you can see the bridge in between. You could very well see the bridge in between the two septums, and we are going to the other half of the cavity, and we have entered into the right half of the uterine cavity. Now here you can see the right tubal ostia. So very easy to not only diagnose but also treat simultaneously. So we have now started correcting the septum by resecting the septum using the Hollin's knife. A very easy daycare surgery under, you can say, using normal saline as the distension media, and bipolar current is used. With resectoscope, this septum can easily be cut. We have started cutting the septum from the left cavity, entered the right cavity. Here you can see the upper half of the septum being resected. Septum being a vascular structure, just giving us cut is going to resorb the septum, and usually it does not bleed. Only towards the upper, you can say near the myometrium, there can be some vascularity. So keep always the tubal ostia in vision and go on resecting the septum. And these patients will have a very good prognosis. Once the cavity is turned into a single uniform cavity, the prognosis of this patient, it becomes very, very good. So a very rewarding surgery, a daycare surgery, hysteroscopic septal resection being done under normal saline as the distension media, bipolar current being used. So you can see now we have reached towards the fundus. You will start seeing the pinkish myometrial fibers. Always better to undercorrect so that there is no perforation and the strength of the fundus is maintained. Here you can see the right tubal ostia and the leftover septum being resected. Usually we leave the intracervical part of the septum many times because that keeps the strength of the cervix maintained, or you can remove that and then give a encerclage simultaneously, because this patient will require cervical encerclage during their pregnancy. Here you can see a unified uterine cavity at the end. Similarly, uterus didelphys you can see here on laparoscopy. Two separate uterine horns with the sigmoid going in between, and each horn having one tube and one ovary. So two separate uteri. This is uterus didelphys. Two separate cervix she had. So such anatomical factors have to be ruled out, and wherever possible have to be corrected. Then we have to rule out genetic factors. We already saw a very nice case of translocation resulting into recurrent pregnancy losses. So translocation, inversions, you can say single gene deletions, all these can result into recurrent pregnancy losses. So karyotype or microarray of the parents is very important. If possible, we can do microarray of the abortus. So advantages of ruling out genetic factors is we can then treat accordingly. We can do pre-implantation genetic diagnosis. So pre-implantation genetic diagnosis will ensure that we are putting a genetically healthy pregnancy back into the uterus. So the chances of miscarriage would be reduced, less emotional disturbance, and will shorten the time to pregnancy. Of course, the disadvantage of pre-implantation genetic diagnosis is that the cost gets added because you will have to do IVF and then genetic checking of the embryo. So genetic counseling of patients with recurrent pregnancy loss is very important. We have to rule out translocation, inversions, and other genetic, you can say, variations. And pre-genetic testing can be one very good way out. After looking at the genetic factors, important other factors causing recurrent pregnancy loss is the immunological factors. And in immunological factors, we have to rule out the alloimmune factors and the autoimmune factors. And the alloimmune factors is basically the failure of the maternal immunological adaptation to the developing conceptors, resulting in a transplantation rejection like reaction. So if the pregnancy is considered as a foreign body by the mother, and each pregnancy is being rejected considering it as a foreign body, then this is known as alloimmune rejection. So how we can diagnose it and treat it is important. The investigation for these is husband-wife lymphocyte cross-match, wife TNF-alpha levels, wife natural killer cell activity levels. Treatment is either active and or passive. Active treatment is with lymphocyte immunotherapy. Passive treatment is with low molecular weight heparin, steroids, immunoglobulin, intralipids, or TNF-alpha inhibitors. So, and overall the prognosis becomes very good. Usually alloimmune factors causing recurrent pregnancy loss is a very, very rare incidence or overall a very small chunk of RPL. More common are the thrombophilias or the acquired, you can say, thrombophilias. That is the Appler syndrome is more commonly seen. So Appler syndrome or the Hughes syndrome, basically it presents as varied, you can say, clinical scenarios. It can be classified into primary antiphospholipid syndrome or secondary antiphospholipid syndrome, depending on whether it is associated with a connective tissue disorder or not. Because many times antiphospholipid syndrome or antiphospholipid antibody syndrome is associated with connective tissue disorders like SLE or Sjogren's syndrome. And it can present right from varied presentation like obstetric complication, or it can be classical antiphospholipid syndrome with recurrent thrombosis, or it can be just non-thrombotic, non-obstetric type, or a seronegative antiphospholipid syndrome. What are the diagnostic criteria for antiphospholipid antibody syndrome are the revised Sapporo's criteria. One clinical and one laboratory criteria has to be met to label a patient as antiphospholipid antibody syndrome or APS. And what are these clinical and laboratory criteria? Lab criteria are lupus anticoagulant, anti-cardiolipin antibody IgG IgM in medium to high titer, anti-beta 2 glycoprotein IgG IgM in medium to high titer. And the clinical criteria are history of vascular thrombosis, one or more unexplained pregnancy loss after 10 weeks, or 3 or more unexplained consecutive losses less than 10 weeks, or one premature birth due to eclampsia or severe early onset preeclampsia. So if one clinical and one laboratory criteria is met, then antiphospholipid antibody syndrome is diagnosed. And the treatment is a combination of ecosprin and low molecular weight heparin. Prognosis becomes very good if we treat properly with ecosprin or aspirin and low molecular weight heparin. Inherited thrombophilias again form a small and a rare chunk of recurrent pregnancy loss, and this can be due to factor V laden mutation, prothrombin gene mutation, antithrombin 3 deficiency, or protein C proteinase deficiency, or methyl tetrahydrofolate reductase deficiency. Again, the treatment is similar to acquired thrombophilia, combination of aspirin and low molecular weight heparin. Endocrinological causes of recurrent pregnancy loss. Again, it forms a good big chunk of recurrent pregnancy loss. Patient, almost 15% patient with recurrent pregnancy loss can have endocrinological causes. And the most common endocrinological causes seen are thyroid abnormalities, PCOS, luteal phase defects, diabetes mellitus. So basically, thyroid abnormalities, we have to screen all patients with recurrent pregnancy losses for their thyroid function test along with thyroid antibodies, and any subclinical hypothyroidism also has to be corrected. The target should be TSH of 2.5 or below. Luteal phase defect due to hyperprolactinemia, PCOS, hypogonadotropic hypogonadism, poor ovarian reserve, stress, all this will result in decreased progesterone production by corpus luteum and dysfunctional endometrium to support the pregnancy, resulting in pregnancy losses. Almost 12 to 20% of patients with recurrent pregnancy loss do have luteal phase defect. And so we have to supplement patients with recurrent pregnancy loss with progesterone, either oral dihydrogesterone or vaginal progesterone. PCOS again is an important cause of endocrinological cause of RPL. Again, PCOS is resulting into hyperinsulinemia, insulin resistance. It will result into luteal phase defect, obesity, improper ovulation, and thus resulting in improper achievement of pregnancy and also pregnancy losses and luteal phase defect. So we have to take care of PCOS if it is present. Diabetes mellitus can also be a cause of recurrent pregnancy losses. Most important and neglected one is the diminished ovarian reserve. Many times I have seen that premature ovarian aging can be a cause of RPL is not considered itself. So doing AMH for patients with RPL is many times neglected. It is very good to look at the ovarian reserve, and if the ovarian reserve is poor, that can be one of the cause for recurrent pregnancy losses. Again, the sperm being looked for recurrent pregnancy loss is commonly neglected, and many times the husband is not considered as a etiological factor for recurrent pregnancy losses. But almost you can see 20 to 25% patients with recurrent pregnancy loss, the husband would have high sperm DNA fragmentation index, which needs to be corrected. So looking at the sperm DNA fragmentation index is important in patients with recurrent pregnancy losses. Hyperprolactinemia again can cause recurrent pregnancy loss. So these are where the various endocrinological causes which we need to look at and rule out and treat in patients with recurrent pregnancy losses. We also have to look at the microbiological factors, and overall microbiological factors causing recurrent pregnancy loss is very rare as such. Sorry. Only bacterial vaginosis or mycoplasma infection can result into recurrent PPROM and preterm labor, resulting in pregnancy losses. One take-home message is torch infection can never cause recurrent pregnancy losses. So screening for torch infection in patients with recurrent pregnancy loss should be abandoned. Lifestyle factors should be corrected and should be looked at. Cigarette smoking, alcoholism, obesity, excess of caffeine, excess of stress, all these are known factors to cause recurrent pregnancy losses. So these have to be taken care of. And as it is well known that tender loving care forms an important, you can say, treatment for recurrent pregnancy loss couples. So proper counseling, psychological support, tender loving care is one of the important ingredient in the treatment. So the take home message is we have to rule out various causative factors and treat all these causative factors properly before going for next pregnancy. Unless we have looked at all the factors, we have corrected all the factors. It is better not to achieve the next pregnancy. And this is a summary of various factors and the various tests which we should do in recurrent pregnancy losses patient, and what are the do's and don'ts. So coming to the take home message, just last 1 or 2 slides. So what are the do's? Please check for acquired thrombophilias, that is lupus anticoagulant, anticardiolipin antibody IgG IgM, anti-beta 2 glycoprotein IgG IgM. We should evaluate for anatomical malformation, anatomical acquired or congenital malformations in the you can say uterus and the cervix. Chromosomal microarray is preferred to normal karyotype because it has given a higher rate of successful assay. Also, genetic abnormalities should be ruled out. Thyroid, prolactin abnormalities, diabetes, so endocrinological factors, lifestyle factors should be ruled out. What are the don'ts? Please do not check for other thrombophilias or other rare, you can say, investigations of thrombophilias, and do not consider low positive antiphospholipid immunoassay to be indicative of antiphospholipid syndrome. Do not perform unnecessary DNCs. Do not measure luteal phase progesterone levels. No point doing TORS test again and again, because I have seen many times as soon as patient with RPL is seen, TORS tests are advised. There is no reason of advising TORS test. Only we have to see is whether the patient is immune to rubella or not. And if the patient is not immune to rubella, it is better to vaccinate with the rubella vaccine before going for next pregnancy. So thank you all for your patient listening. I have tried to be as short and practical as possible for this vast topic of RPL, which we see. I am confident that you all specialists and family physicians daily would see patients or couples with recurrent pregnancy loss in your practice. And I thank once again to you all for your patient listening. I also thank to all my colleagues and IVF specialists and my team at Indira IVF Pune. Thank you. Over to the organizers.
Yes. Thank you, sir. It was a very effective and see all thorough investigations and evaluation of this recurrent pregnancy loss is a must, because you don't know what factor is affected and what is the cause of this recurrent pregnancy loss. And when the couple comes to us, they are in a very desperate condition, and with couple, all their family members, they also add to the point. So it becomes very difficult to treat such patients with the patience and with all this thorough examination. Thank you, sir. So, sir, there is one question. You can read it out. It's I'll read for you. Sir?
Yes.
There is one question.
Yes. Sorry.
You can read.
Question. Just a minute.
I'll
I'm not
read
able to. Yeah, if you can read. Yeah, a newly married female consume OC pills for a year post marriage. Now the couple desires a pregnancy, and the OC pills have been discontinued. Does this medication have any delayed effect? Are there any other tests that the couple should go through prior to conception to ensure safe outcome? This is the question, madam.
Yes, sir.
So basically, any couple who is wanting to plan for a pregnancy, certain set of preconceptional tests should be done, and certain preconceptional counseling should be done. They should be advised to start with folic acid. So the common test which we should do is to know the blood group of the couple. We should know the infection status, if they are having any you can say the serostatus should be known. If they are having any infections which will be detrimental for the pregnancy, that should be known. There are certain carrier status like hemoglobinopathy should be ruled out, thalassemia, sickle cell anemias. So these are certain basic tests which we do before planning a pregnancy. We also rule out whether she is immune to rubella or not, because if the wife is not immune to rubella, then it is better to vaccinate her before planning the pregnancy itself. So these are certain basic tests. We also look at the TSH prolactin levels of the wife, because if there is any, you can say hypothyroidism or subclinical hypothyroidism, that can be corrected. So these basic tests before planning pregnancy. Now the second part of the question was whether the OC pills was going to have any effect on pregnancy or not. So because she has already stopped her OC pills and her subsequent menstruation are regular, I don't think these OC pills are going to have any effect on the subsequent pregnancy. So no need for the couple to worry that they have taken OC pills in the past. Now these OC pills are not going to have any detrimental effect on the coming pregnancy.
Yes, thank you, sir. Thank you very much. I will request our president, Dr. B.L. Deshmukh, to felicitate you.
Sir, this is bouquet for you.
Thank you, sir. Thank you. Thank you.
This is IMA Pune.
Thank you, madam. Thank you. Thanks a lot.
Thank you, sir. Thank you.
Thank you.
So now, welcome Dr. Ramesh Gaikwad, sir, and good afternoon. So now the next lecture will be by Dr. Ramesh Gaikwad, sir. It is on approach to an infertile couple. I will introduce Dr. Ramesh Gaikwad, sir. He's an MBBS and DNB obstetric and gynec person. He's an IVF specialist and gynec laparoscopic surgeon. He's got vast 10 years of experience in infertility management. He's an author and co-author in 8 publications, that is national and international journals, and around 7,000 embryo transfers has been done. So over to Dr. Ramesh Gaikwad, sir. Yes, sir, you can start.
Yes, am I audible, madam?
Yes, sir. Yes, sir. And your slides also.
Good afternoon, everybody, and thank you, madam, for those kind words. I will discuss today on approach to an infertile couple, because we all know that infertility is such a growing concern, and we come across this problem in our day-to-day practice, and one should know how to approach or evaluate those couples to come to one conclusion, so that it will be easy to treat them and to get success in those cases. While going through this topic, I will cover this definition, causes of infertility, evaluation of couple, and as well as specific investigations to come to conclusion. So to start with definition, infertility is an inability to conceive after 1 year of regular unprotected sexual intercourse. And if those couple are not getting conception after sexual intercourse for almost 1 year, then in those cases, we need to start evaluation whether there is any problem with male side or female side, and we should start evaluation. And this time duration should be reduced to 6 months if those couple are having certain problems, like female partner age is more than 35 years, having genital or abdominal tuberculosis history, or she had previously detected with moderate to severe endometriosis or any other ovarian surgery done. And male partner, if underwent testicular surgery previously, need to start evaluation after 6 months duration only. So we should consider 6 months as an optimum time for them to get conceived. And if they are not getting conceived, then definitely we need to hurry up for investigations. This infertility is divided into 2 types. First is primary and other is secondary. Primary, where there is no previous history of pregnancy, and in secondary there is past history of pregnancy, irrespective of its outcome, whether it was spontaneous abortion or pregnancy continued till delivery or any stillbirth or any other, even ectopic also we consider as a past history of pregnancy. Almost 10 to 15% of reproductive age group couple face this problem. Though prevalence of infertility is stable, demand for infertility care has increased nowadays, and this mainly is because due to increased awareness about infertility. Majority people, they think that infertility is like other illnesses and can be cured or treated with medicines. Also, there are certain sociological changes which have occurred over the last few decades, like delayed marriages, as well as delayed childbearing due to career orientation, as well as this stress factor related to work pattern nowadays also has reduced sexual frequency drastically, and that is the main reason behind infertility in educated couple. Coming to this pictorial representation, representing as a reproductive system, we can see here female genital organs, male genital organs, and here you can see this HPO axis, hypothalamo-pituitary-gonadal axis, which is the main hormonal cascade which takes center stage in this reproductive system. In this, if there is any abnormality or any problems occur in this HPO axis, there will be formation of defective gametes, either male or female gamete, and further their functional ability, and it leads to infertility. So coming to male infertility causes, just for simplicity, we have divided it into pre-testicular, post-testicular, testicular, as well as post-testicular causes. In pre-testicular causes, mainly hypogonadotropic hypogonadism, where there is problem with hypothalamus, where there will be less secretion of GnRH hormone from hypothalamus, leading to inappropriate stimulation of pituitary and further HPO axis problem. Also, coital disorders in the form of ejaculatory failure, which is mainly due to occur due to spinal cord injuries, uncontrolled diabetes mellitus, also as well as other chronic illnesses like multiple sclerosis, chronic renal failure, and drug-related reasons. Erectile dysfunction is also one of the reasons, and it can be either congenital, due to congenital vascular problems, as well as secondary problems like psychological, alcohol or drug abuse, and uncontrolled diabetes. Loss of libido is mainly occurring due to some hormonal problems, and common among these are hyperprolactinemia in male. Then retrograde ejaculation, where there will be retrograde ejaculation will be occurring into the bladder instead of coming out, and it is mainly due to damage, anatomical or neurological damage at the bladder neck, and it is due to transurethral prostatectomy, retroperitoneal lymph node dissection, or uncontrolled diabetes, which leads to damage to bladder neck and leading to retrograde ejaculation. Testicular causes are basically congenital causes, some genetic causes. Absence of it is called as anorchia. If there is undescended testes, it is called as cryptorchidism. This lead to azoospermia later on. Then genetic causes like Klinefelter syndrome, Y chromosome microdeletion, then immotile cilia syndrome also seen now in many cases. Then infective pathology mainly occurring in kids, that is mumps, orchitis, as well as sexually transmitted diseases are also taking quite chunk of these causes. Then antispermatogenic agent exposure to heat, irradiation, chemotherapy, and drugs are also leading to defective sperm formation and its quality. Then vascular causes like torsion of the testes, then varicose, where there will be pampiniform plexus dilatation, and it slowly causes decrease in count, quality of the sperms, and functional ability. Then immunological causes like anti-sperm antibodies present in either semen sample or serum also causes defective sperm production as well as their quality. Then idiopathic is a reason where actually it is considered under congenital testicular dysfunction syndrome, where there will be certain changes occur during fetal life of the male fetus, where these testes, Sertoli cell formation as well as germ cell formation will be defective, and further leading to defective or inappropriate production of the sperms and its functional ability. Then post-testicular reasons are like obstruction at the level of epididymis or vas deferens. In vas deferens, actually congenital bilateral absence of vas deferens, we are seeing many patients, almost it takes 10% of the cases of azoospermia cases. Then cystic fibrosis also we come across nowadays. Then acquired reasons are like vasectomy inadvertently done vasectomy, then infection leading to blockages of the vas deferens, then infection at the male accessory gland infection, male accessory glands like prostate, seminal vesicles, leading to inappropriate secretion of the their secretions, which is the integral part of the semen sample, and also chances of anti-sperm antibodies formation in that semen sample is more. Then immunological, like idiopathic as well as post vasectomy causes are also there. Then coming to female causes, female fertility, we again divide it into ovarian, pre-ovarian, ovarian, and post-ovarian for our simplicity. In pre-ovarian, again, this hormonal cascade is taking main part. In this, hypogonadotropic hypogonadism is seen, although it is very rare, one of the rare cause. Still, we come across few cases. Then most common cause in this pre-ovarian region is hormonal imbalance, and we consider we term it as a polycystic ovarian syndrome. In this, actually, there will be defective formation of follicular stimulating hormone as well as its stimulus over the on ovaries, and further leading to inappropriate folliculogenesis, then production of the excessive androgen, and further problems like in infertility and obesity, then acne, hirsutism. These are the symptoms. Then along with this possibility, we come across with micro or macroadenoma of the pituitary. Then thyroid illnesses also come in this category. Then coming to ovarian causes, there will be ovarian cyst ranging from simple follicular cyst to complex solid masses. This leads ineffective or defective folliculogenesis. Also, sometimes there will be ovulation occur, but because of anatomical hindrance, these follicles will not be, or these oocytes will not be picked up by tubes, and thus leads to infertility. Along with this cyst, there will be endometriosis, which is one of the common reason here, and this endometriosis leads to adhesions, peritubal adhesions, ovary, both ovaries will be adherent to each other. So depending on the stages of the endometriosis, damage or adhesions will be there, and it helps, it affects tubal motility as well as oocyte pickup. Then post-ovarian causes are mainly related to fallopian tubes. Infection to fallopian tube leads to damage to musculature of the tubes, and it affects tubal motility and further oocyte pickup. Infection, if it is more, then it leads to blockages of the tubes, further salpings, pyosalpings, and almost permanent damage to tubes and permanent inability or infertility. Then next cause will be related to uterus. If there is any large fibroid or adenomyosis which are causing damage to endometrium or protruding into the endometrium, it also affects the tubal. It also affects or blocks tubal openings, and further leads to infertility. Then causes related to endometrium are mainly due to infection, which are tuberculosis, chlamydia infection, or infection introduced while doing some certain procedures like DNC, curettage. In some cases where we think that if we do curettage, new endometrium will come, and that will be helpful or suitable for pregnancy. But many times it will affect endometrium, and sometimes it will introduce infection and further leads to adhesions inside the endometrial cavity and leads to further asherments and sometimes permanent damage to endometrium. Then sometimes even cervical causes like infection to cervix, cervicitis, chronic cervicitis, and infection to glands leading to formation of this infection to glands lead to presence of anti-sperm antibodies into the cervical mucus, or composition of the cervical mucus will be changed, so that these sperms will not cross these sperms, this cervical mucus properly, and ascending of sperms will be affected, and that again helps or lead to infertility. So these are the main reasons from female point of view, and in broad sense we can see genital tuberculosis, which will its toll almost everywhere at pelvic causes, ovarian level as well as endometrium level also it affects. And out of these, mainly these reasons for infertility are related to pelvic as well as tuberculosis, tubal factors. Then ovulatory dysfunction will be seen in 25% cases, and unexplained cases will be up to 5 to 10%. So while evaluating this couple, we need to focus on the couple in all, not only one partner, regardless of the partners should be encouraged to visit every time, because we need to assess their attitude towards treatment, and we should see whether there is only one partner who is really willing for treatment, other partner is just getting forced for this. So we need to assess that, and then identify any important underlying medical condition, so that we may need specific attention to for that. And evaluation of male partner should begin at the same time as like female partner, because many times we say that majority patients all female evaluation is done, but male partner is not getting evaluated many cases. So one should not do that. So while evaluating, most important part is to stress is on history, because here in history we need to say female age, which is one of the most important factor, because of with increasing age, number of eggs and sperms will come down. So age and trying time should be noticed. Then detailed history of the couple should be mentioned, like menstrual history for female, how is regularity of the menstrual cycle, what is pattern of the bleeding, whether there is dysmenorrhea along with that. Then past obstetric history, is there any mishap, multiple abortions. Then other medical or surgical illnesses and drug history we should note. Then coital history, which is very important, because majority time what happen, this couple sitting next to you, they hesitate to give this particular history. So one should ask them particularly about coital history, whether they are having proper intercourse or what is frequency of intercourse. And then we need to know about any previous history of pelvic inflammatory diseases, sexually transmitted diseases, or treated for them, and also thyroid illness. Then use of contraceptives or emergency pills. Actually, if they are using any longer acting contraceptives, because these longer acting contraceptives, once discontinued, their effect remain for a few months after discontinuation, or sometimes some certain contraceptives generally they affect endometrial receptivity also. So we should stress on this contraceptive history also. Then environmental and occupational hazard. This is more common, more important male point of view, because in this we should ask occupation of the male partner, because majority of these couple or husband, they generally work near boiler or furnaces, that is heated areas. So in those cases, or certain factories like color factories, where these fumes causes damage to sperm production as well as their quality. Then next history should be asked about galactorrhea, hirsutism, or such any signs of this hyperandrogenism or excessive other hormonal hormones. Then addictions in couple we should evaluate. Then any history of family history of early menopause, because if there is any such family history in such couple, again this female will have less number of oocytes, as well as their ovarian reserve will be less, and in those cases we need to think of early evaluation. So it is rightly said that listen to your patients, they are giving you diagnosis. While evaluating, one should examine couple with general examination. To complete gynecological examination, we need to examine breast, perspectivum, and pervaginal examination. For husband, we need to ask for smell sensation, because it is present in anosmia is quite commonly seen in hypogonadotropic hypogonadism, that is Kalman syndrome. Then gynecomastia in Klinefelter syndrome or androgen excess. Then we need to examine properly about external genitalia and scrotal examination. In scrotal examination, we need to see whether there is any lesions on the scrotum, any surgery marks, or any hydrocele or any other problems related to scrotal skin. Then testicular volume, testicular consistency, and size of the testes we should examine. Then penile examination, whether there is opening, where that opening of meatus is situated, is there hypospadiasis, is there phimosis, we should rule out. And while doing investigations along with general investigations, blood test we should do for this sexually transmitted diseases like HIV, HBsAg, SCV, and VDRL in both. So after this general investigations, we need to investigate or evaluate for specific tests, and these are basically 3 tests we do, and that is male gamete, female gamete, and uterus with fallopian tube. So these, if we start evaluating, when one should start evaluation with male partner, because evaluating or investigating semen sample is very easy, and this test is also quite commonly available. So this semen sample will be seen with naked eye, like this white color fluid. And one should see under it under microscope for its morphology, whether how is head, neck, and body of the body, tail of the sperms, and their functional, as well as certain functional tests or advanced tests are also done, like DNA fragmentation index and all those for sperm functional ability. While doing semen analysis, one should exclude recent febrile illnesses, and collection of the semen sample is better by masturbation. If patient is having problem with the masturbation, then they can even collect the semen sample by having intercourse. But while intercourse, they need to use male pack or condoms without any spermicidal jelly. About abstinence, there are many thoughts, like many people, they think abstinence should be more, but if this abstinence is more than 7 days, then count will be more, but majority of these sperms will be dead, and due to these dead sperms, these reactive oxygen species will be released, and that will damage whatever normal sperms are there. So the number of sperms will be more with more abstinence, but quality of the sperms will be. So abstinence of 2 to 3 days is enough. And even if there is no abstinence, then also we can check sample, because concentration will not change with number of days, or will not change with volume. Then analysis of the semen should be done after complete liquefaction only. If it is not completely liquefied, then definitely this count and quality will not be proper. Then this semen analysis should be done at a well-equipped lab with and dedicated technician should be there. Otherwise, it will not be reliable. About quality, this motility and morphology is more important than count, and there is no benefit doing computer-assisted semen analysis over manual analysis. Manual analysis is commonly used, and it is reliable. So one should not rely on one semen analysis report, and because there are certain disadvantages with single semen analysis, because these parameters may vary from sample to sample, technician to technician, and lab to lab. Also, one normal report do not confirm fertility potential of a female, and this conception can be possible even with very bad sample, and the man may be fertile to one female and infertile to another female. So only one sample report should not consider as a final. According to consensus, WHO has given some lower reference limit in 2010. According to them, semen volume should be more than 1.5 ml, sperm concentration should be more than 15 million per ml, and total sperm in that ejaculate should be more than 39 million. Progressive motility should be more than 32, and combined motility should be more than 40%. Normal morphology should be more than 4% to say this semen sample as a normal. Then when to go with chromosomal and genetic studies, it should be done in azoospermia cases as well as severe oligozoospermia, where this semen sample or semen count is less than 10 million per ml. Then endocrine evaluation should be considered when there is abnormal semen analysis, that is semen sperm count is less than 10 million, or there is sexual dysfunction. This hormonal evaluation is done in the form of serum FSH, follicle stimulating hormone, and serum testosterone. If there is low serum testosterone, then we need to go with free testosterone, which is active form of the testosterone, then luteinizing hormone and prolactin thyroid hormone evaluation in those cases. How to interpret this hormonal evaluation? If it is hypogonadotropic hypogonadism, then all these follicle stimulating, luteinizing hormone and testosterone hormone level will be less. If there is only abnormal spermatogenesis, then generally this FSH will be normal or slightly high. LH and testosterone will be normal. Then testicular failure, in those cases increased level of FSH and LH will be there with low testosterone levels. Sorry. And prolactin secreting pituitary tumor, there will be almost normal gonadotropin level with low testosterone and increased prolactin levels. Imaging is indicated in certain cases only. The transrectal ultrasonography TRUS is done to diagnose ejaculatory duct obstruction, where there is severe oligozoospermia or azoospermia along with semen containing little or no fructose, but vas is palpable and low volume ejaculate. In those cases, we can go with transrectal ultrasonography. If we are doing seminal vesicle aspiration and vesiculography along with this transrectal ultrasonography, it gives us definitive diagnosis of this ejaculatory duct obstruction. Transscrotal ultrasonography is done for scrotal mass, varicocele, and in those cases, if we are seeing unilateral or bilateral vas basal agenesis, absence vas deferens, it is associated with the some cases of renal agenesis. After evaluating male gamete, second is female gamete, that is oocyte or egg. We can see here mature oocyte. In first figure, we can see this oocyte along with corona radiata around it, and after denudation, this oocyte, mature oocyte, is seen with extruded polar body here. Testing for oocyte or egg is mainly test for ovarian reserve as well as test for ovulation. So ovarian reserve, we have two important or most commonly used tests are antral follicle count and biochemical biomarker in the form of AMH or anti-Malarian hormone. So ultrasonography, properly done ultrasonography gives us quite good idea about female fertility potential. In this, you can see first figure here we are seeing these small cystic spaces. These are the follicles which are arranged peripherally in the ovary. These antral follicles are considered which are 2 to 9 millimeter in size, and if any ovary containing more than 5 antral follicles, that ovary considered as a normal ovarian, having normal ovarian reserve. If both ovaries are containing normal ovarian reserve in all total, this ovarian reserve of that particular female is considered normal. If that ovary is containing less than 5 follicles, we will consider it as a diminished, and overall both ovaries are containing less than 5 follicles, then we'll consider as a diminished ovarian reserve picture. Along with this, we go with a biomarker, that is anti-Malarian hormone. This anti-Malarian hormone is produced by antral follicles, and these antral follicles, actually it is a direct marker of primordial ovarian follicle pool, and it is secreted by these follicles while growing these follicles up 8 meters, generally this AMH production will be almost stopped by those follicles. This is a very important biomarker for ovarian reserve. And in female, it is remaining almost undetectable at birth, while it starts increasing after birth and peaks at the late puberty. Once they start menstruation or at the menarche, it level will be at highest, and it will be slowly come down slowly with decreasing reserve and remains unremarkable after menopause. It is advantage of this AMH because level of the AMH remains constant throughout cycle, whether it is day 1 or day 2 or day 16, 17, it remains same. So any day of the cycle we can perform this test, not like FSH or LH, which is generally performed within first 3 to 4 days of the menstruation. AMH is also known as Mullerian inhibiting substance, and it is secreted by Sertoli cells in males. And generally, we don't use this hormone to evaluate male partner, but it is exactly in opposite direction, opposite to female in male. What are the factors affecting anti-Malarian hormone? Generally, levels will be low when there is vitamin D deficiency or previous treatment with OC pills. Then in obese cases, also with smoking and tobacco users, this level will be less. Then previous history of chemoradiation or radiotherapy. Then oophorectomy indirectly reduces the primordial ovarian pool, and that's why it decreases the AMH level. Then ovarian cystectomy or any other ovarian surgery. Autoimmune diseases like thyroid diseases or SLE also decreases the AMH level. And high levels will be seen in polycystic ovarian syndrome cases, granular cell tumor of the ovary. What is the clinical significance of this anti-Malarian hormone? We use this in and it gives us idea about the premature ovarian aging, so that we need to go with early treatment in such cases. It helps in diagnosis of the polycystic ovarian syndrome along with other polycystic ovaries, other markers like polycystic ovaries, hyperandrogenism or other signs of the hyperandrogenism. Then prediction of poor ovarian response in IVF cycles will be its main significance, and it helps in such cases. Then talking of ovarian hyperstimulation prevention program, if there is if this AMH is more in certain cases, we need to personalize our stimulation protocol according to case, and so that we can prevent hyperstimulation and its complications. It is help to know ovarian reserve, and hence we can cryopreserve eggs in certain career-oriented female, so that egg freezing will give us better idea, and we can use those eggs after a certain period. Then forecasting reproductive lifespan will be possible with this AMH, because if we come to know that if there is good reserve, ovarian reserve, then even we can prolong this, or planning can be done according to AMH levels. Then coming to test for ovulation, we have sonography marker, that is follicular study. So in this we do serial ultrasonography, basically transvaginal sonography we do to see whether how these follicles are growing and what is rate of growth, as well as the documentation of the endometrial thickness and rupture of the ovarian follicle ovulation. There will be certain limitations, because almost some cases we may not be able to see rupture, or may not be able to visualize this follicular rupture, and we may label them as a luteinized unruptured follicle. And test for ovulation sorry. So along with the ultrasound, we have a biomarker, that is serum progesterone, and this serum progesterone level is done on day 21 or 7 days prior to presumed menstruation. And if this level is more than 3 nanogram per ml or 10 picomole per liter, then it is predictive of and it is quite simple Along with this, serum progesterone and follicular study, we have other markers like basal body temperature, LH urinary kit. These are also used for this ovulation testing. After evaluation of male and female gametes, come to evaluate third important evaluation, that is uterus and fallopian tubes. And in this, while evaluating this, we have different modalities like ultrasonography pelvis, and this ultrasonography should be done both transvaginal as well as transabdominal ways, and it is actually beneficial or helping each other. It should be either 2D or along with that 3D scan is also quite helpful. In this, we come to know about uterus, myometrium, endometrium, endomyometrial junction, then fallopian tubes, ovaries, ovarian reserve, as well as any other abnormalities in adnexa or uterus like fibroid, adenomyosis, and all those. Then endometrial thickness, endometrial pattern, as well as endometrial blood flow also we come to know along with this good transvaginal sonography. Then saline infusion sonography or HSG is done to detect fallopian tube patency, and laparoscopy, which is actually has a reserve role for this evaluation of the couple. In certain cases only we need to go with this laparoscopy where there is any pathology in the adnexa which we need to correct, or inside uterine cavity we need to treat or see with histoscopy and remove that lesion if it is there. So certain cases only we need to go with laparoscopy. It has diagnostic purpose, but generally not all cases we need to go with laparoscopy just for a diagnosis. And then as we discussed previously that endometrial tuberculosis is one of the important reason for infertility all over the world, and obviously in India, which is almost around 19 to 20% of the infertility cases are related to this tuberculosis. So one should always be suspicious and should evaluate if there are any suspicious signs for this, and we can easily go with endometrial sampling for endometrial TB PCR and rule out tuberculosis. So while evaluating pregnancy, we have hysterosalpingography where we do this test with radio-opaque dye, which we instill that radio-opaque dye after cessation of the periods around day 7, 8, 9 of the cycle, and we take X-rays, X-ray films, and assess the patency of the tube. But you can see here this films. This dye is delineating the uterine cavity as well as it is seen while going through the tubes, and thus it gives us idea about the patency as well as other abnormality also. Like here we can see this HSG picture is showing tubal block at the femoral, and it is giving appearance of the hydrosalpinx. Saline infusion sonography is also, or saline sonosalpingography, that is SINE test, is also used for the same purpose, and it has little advantage over the HSG, where we don't use radio-opaque dye, which may cause allergic reaction, or it is comparatively less painful than HSG, as well as radiation exposure will not be there. Comparatively, it is more accurate than HSG as well as it gives us proper idea about the endometrial thickness, pattern, and subendometrial blood flow. Also helpful in detect endometrial polyp and submucous fibroid better than HSG, and it is definitely has little advantage because it is real-time study than HSG. Along with tubal patency, even this HSG and SSG helps in the detection of the uterine pathologies like intrauterine pathology, intrauterine lesion, adhesions, or tubal factors, factors like hydrosalpinx and all those can be easily detected. Then uterine assessment in infertility. While doing this uterine assessment, one should evaluate uterine structure in the form of any congenital uterine abnormalities like septate uterus, bicornuate or didelphys uterus. Then uterine pathologies like fibroids or adenomyosis, which are significant in size or affecting endometrial lining, and such fibroids or adenomyosis should be need to treat. Then intracavity pathologies like polyps, endometrial polyps, or any adhesion formation inside the cavity, as well as any fibroids protruding into the cavity. Then along with this, endometrium should be evaluated, and this endometrium evaluation in the form of endometrial thickness, endometrial pattern, as well as endometrial blood flow should be evaluated properly. This endometrium 3-layer pattern is actually good. We consider as a good endometrium if this endometrial thickness is more than 7 millimeter, is considered as a optimum thickness. Then grade type A, type B, or type C, depending on the hormonal effect on the endometrial glands, will give us idea about or gives us pregnancy percentage differently. And vascularization of the endometrium should be checked with the help of this 3D power Doppler, and depending on the presence of the blood supply, whether it is between zone 1, 2, 3, depending on that, this maturity or effect of the progesterone hormone is considered. Then coming to laparoscopy and histoscopy, as we discussed, that it has limited role while evaluating this couple. But if we are finding some lesion on ultrasonography, because nowadays quite good 3D ultrasonography gives us better idea about the cavity or intracavity pathology, any uterine pathology, as well as tubal and ovarian factors. And if we come across any pathology in the uterine cavity or pelvis, which we need to correct, then such cases we need to go with laparoscopy or histoscopy, depending upon the lesion. And other than these cases, generally this laparohistoscopy has hardly any role while evaluating the couple. So to take home message from this is one should consider evaluation of both partners at a time. Many times we come across that only one partner is evaluated, another partner actually has problem, is living, is not getting evaluated. Then proper history and physical examination is key to come to conclusion or diagnosis, and it gives us quite a good idea while treating those patients. Then semen analysis for male and detailed transvaginal sonography for female almost confirm fertility potential of that particular couple. And while treatment, one should consider age, antral follicle count, and AMH as an important factor. And do not forget limited fertility or reproductive period for female, so that if we have limited or if we have a patient with age more than 35, in those cases we need to start evaluating as early as possible, as well as we need to start treatment depending on the factors. Thank you.
Yes. So thank you very much for your such a elaborative lecture, because infertility is such a vast portion, and you have almost touched each and every point of this cause of infertility very well. And I think there are one or two questions. One is this was to Dr. Lunkar sir. Immunoglobulins to be given in RPL. Please explain, and which immunoglobulin?
Usually, madam, we use bar globe or interglobe, which is basically a 2 ml vial, which we give intramuscular once in 21 days for at least 10 doses, starting from the achieving of pregnancy. So in RPL patient, we can use IVIG also, but then IVIG is too costly. And it has no added benefit over other immunoglobulins. So commonly what we are using is either interglobe or bar globe. for patients with recurrent pregnancy loss. And the use is more or less, you can say, empirical.
Okay, sir. Sir, Dr. Gaikwad, sir, there is one question for you. If husband and wife both are obese and they are 30 plus age, what are the basic tests? So I think you have covered everything, but there was a question in the start of lecture. So I think we have covered all the topics, isn't it? Or do you want to answer some?
Actually, here this same blood test which we had mentioned during our evaluation, and obesity we should consider as a main factor here, and definitely obesity in female, which may be along with PCOD. So we should consider these same investigations which we are doing for all others, and to evaluate whether there is any other factor behind this obesity also. So hormonal evaluation in the form of serum prolactin, thyroid, as well as Amol sir had mentioned about rubella vaccination, and proper ultrasonography will give us idea about whether there is polycystic ovary syndrome in female. And in male, again, this prolactin hormone, thyroid hormone we should consider, as well as these investigations which we should do for sexually transmitted diseases like HIV, HBsAg, VDRL, and all these. These routine investigations only we should consider first, and then accordingly we should treat.
Thank you, sir.
And definitely semen analysis for husband.
Yeah, these are the basic tests for the infertility for both of them. So now I think there are no other questions. We'll see if there are questions at the end of the third lecture. So I will request, thank you very much, Dr. Gaikwad, sir. I will request our President, Dr. B.L. Deshmukh, to felicitate you with a bouquet and a token of wishes.
Sir, this is bouquet for you.
Yes, sir. Thank you, sir.
And this is IMA Pune, our traditional. Thank you.
Thank you.
Now, I will request Dr. Amol Lunkar sir to take his second lecture on A to Z of infertility management. So before that, I just want to tell you that tomorrow, in tomorrow's webinar, the topics are of gastroenterology, proctology, and laser by varicose veins, laser therapy for varicose veins, and 3D hernia. Dr. Deepak Kulkarni will be showing that. Dr. Paresh Gandhi will be taking about varicose veins, and Dr. Ashwin Porwal will be taking all the pelvic proctology complications and his management. So please do attend. And this is the third third webinar from this webinar series. So tomorrow will be the last webinar. So don't worry, you should not write your name and everything there, MMC, because as you are registered, your name goes there. So don't worry. So sir, there is a thanks for precise info on dealing with infertile couple from Mukund Savaskar. Thank you. Thank you,
Ramesh,
sir.
if you can stop your screen sharing.
Yes. Dr. Gaikwad sir, stop sharing the screen.
Dr. Ramesh,
Dr.
if you are there.
Yes.
So yes, good afternoon all, and thank you, IMA Pune. Thank you, Dr. Alkashir Sagar Madam and Deshmukh sir, for giving us this opportunity to interact with you all. Basically, what I have done is instead of making it theoretical, the A to Z of infertility management, let us see case by case. So I have kept 3 or 4 interesting cases. You can see my slide now.
Yes, sir.
Yes, yes.
Yes. So
Yes, sir.
I bring you greetings from Indra IVF Pune team, and so let us see a case, and then I'll understand the theory behind that treatment. So this is a 28-year-old housewife, married for 3 years, primary infertility for 2 years, cycles are regular, no coital problems. Her BMI is normal, examination was nothing significant found. Her sonography showed uterus which was normal size, antiverted, antiflex. Antral follicle count was normal, right side 6, left side 7, adnexa was normal. Her investigations, hemoglobin 11.5, thyroid prolactin normal, AMH was 3.2, which is normal. Her husband's semen analysis is normal. Her tubal checking was done by an HSG, which was bilateral free spill. So we have already seen in the lecture by Dr. Ramesh how we evaluate an infertile couple. So these are the important investigations which we definitely need while we evaluate an infertile couple. Now this couple who is married for 3 years, primary infertility for 2 years, has undergone all the evaluation, and more or less if you see all the investigations are normal, but still there is no conception. So what next to do, how to manage such couples? So usually young couple married for short duration, infertility for 2 years, what we usually do is start with ovulation induction with timed intercourse. So what is ovulation induction? Basically, ovulation induction is using of various pharmacological agents to convert an anovulatory female to an ovulatory female. So if a female is anovulatory or having oligo-ovulation, then to make her ovulate, we use various pharmacological agents. In ovulating females, also we use ovulation induction to make them super ovulate so that they form 2 or more follicles, and thus their chances of achieving pregnancy increases. So usually in young couples with short duration of marriage, with all the reports normal, we would start with ovulation induction with timed intercourse. We will explain them about the fertile period. We will start them with preconceptional folic acid, and ovulation induction can be done with various agents, like right from lifestyle modification to oral agents like clomiphene citrate, or aromatase inhibitors like letrozole, anastrozole, or selective estrogen receptor modulators like tamoxifen can also be used. We can use injectables, that is human menopausal gonadotropin or FSH, that is follicle stimulating hormone, or you can use a combination of oral and injectable agents. And in certain patients, you might require to add adjuvants like metformin, myoinositol, antioxidants. So these are the various ways in which we do ovulation induction. The most common agent which is used for ovulation induction worldwide is clomiphene citrate. You all know that. It is a selective estrogen receptor modulator, and it basically blocks the estrogen receptors at the hypothalamus pituitary levels. And so the negative feedback of estrogen to the pituitary and the hypothalamus is blocked. And so more FSH is released and more follicles are recruited. Letrozole or anastrozole are aromatase inhibitors. They basically inhibit the aromatization, that is conversion of testosterone and androgens to estrogen. So less of estrogen would be available, and so the negative feedback of estrogen to the hypothalamus and pituitary will be, you can say, less, and so more FSH would be released. That is the way clomiphene citrate or letrozole acts. Now, how we give ovulation induction? So in a infertile couple, when we plan to give ovulation induction to the female, we have already done the evaluation of the couple completely, as was described by Dr. Ramesh Gaikwad in the previous lecture. And then what we do is do a baseline scan on day 1 or day 2. Baseline scan is very important to know about her antral follicle count, to know about the endometrial cavity, to know about her status of the ovary and the endometrium before starting ovulation induction, so that we rule out any pre-existing cyst, any luteinized unruptured follicle of the previous cycle. All this should be ruled out. Once we do a baseline scan, then we start ovulation induction drug. It can be clomiphene citrate or letrozole or anastrozole or tamoxifen. Basically, The choice would depend on the basically the overall reports, whether she is known case of PCOS or not, how she has responded to her previous ovulation induction drugs. Most commonly used is clomiphene citrate, and the dose can vary from as low as 25 mg to as high as 200 mg. Commonly used doses are 50 mg and 100 mg. We start we start the oral ovulation induction drug from day 2 to day 6 of the cycle. Any day we can start and give them for 5 days, and then subsequently look by doing serial follicular study or serial transvaginal sonographies to look for dominant follicle formation. Once dominant follicle formation happens and the follicle reaches a size of around say 20 mm or so, we basically if we are planning to give a trigger or help in ovulation, then we might use HCG. Once the follicle reaches a size of around 14 mm or so, that is the time when we ask the couple to have alternate day intercourse or daily intercourse to achieve pregnancy. So once ovulation is confirmed, we give luteal phase support in the form of oral dihydrogesterone, or you can use micronized progesterone. And of course, luteal support would not be required in all patients where we are using oral agents. It would be required especially when we are adding injectables, or when the patient is having known factors which are going to cause luteal phase defect, or she is oligomenoric, or she is having severe PCOS. So in those patients, luteal phase support would be required. But this is by and large to give an idea how we do basic ovulation induction in a young infertile patient. So letrozole you can use in a dose of 2.5 milligram once daily for 5 days. You can extend up to 7.5 milligram once daily for 5 days. Tamoxifen is used in a dose of 40 milligram once daily for 5 days. You can go up to 80 milligram once daily for 5 days. So these are the commonly used ovulation induction drugs. You can, along with ovulation induction, we can do timed intercourse, or later on you can add on with intrauterine insemination also. So this patient who was having primary infertility for 2 years, ovulation induction was done with timed intercourse. 2 cycles were given by her nearby doctor. Clomiphene citrate was used 100 milligram. Then later on 2 cycles were given with letrozole 2.5 milligram. Ovulation was happening in all 4 cycles, but she still did not conceive. So she has had 4 cycles of ovulation induction with timed intercourse, no conception. What next? So in such patients who are unexplained infertility with ovulation induction and timed intercourse failure, we usually think of adding of intrauterine insemination along with gonadotropins to increase the success. Gonadotropins will help the female to superovulate and increase her chances of achieving pregnancy. IUI would add on by, you can say, overcoming the cervical factors, overcoming the you can say coital factors, thus can add to the success and increase the success in such couples. So the next option for such couple would be ovulation induction with gonadotropins along with IUI for 2 to 3 cycle. Now the way we give gonadotropins can be varying. There are various protocols. The most commonly and the standard one used, or the safest one used, is the low dose step-up protocol. We have to remember, whenever we are adding gonadotropins, our monitoring with sonography has to be much closer. We have to basically monitor for ovarian hyperstimulation. She will have a chance of almost 20% conception in a single cycle of gonadotropin plus IUI cycle. So a single cycle of IUI with gonadotropin in such couples would give a success of around roughly 20%. And let us see about IUI in short. Intrauterine insemination, or IUI, is basically deposition of washed spermatozoa in the uterus above the level of internal os around the time of ovulation, and this will help us in overcoming the vaginal acidity, the cervical mucus hostility. It will help us to deposit highly motile, morphologically normal sperm in the uterus at the time of around the time of ovulation. So what are the indications of IUI? So mild to moderate male factor, that is mild to moderate oligospermia, asthenospermia, teratospermia or hypospermia, coital problems, erection, ejaculation issues, or you can say non-availability of husband if he's working somewhere else and the couple is not able to cohabitate properly. They do not get time, or they are working in totally different shifts. So all these issues, IUI would be helpful. Or in patients where cryopreservation of sperm is done in cases of cancer treatment. So before going for chemoradiation, a couple who has not completed their family should be advised to undergo gamete freezing, either the egg freezing in case of female or the sperm freezing in case of male. And these freezed gametes can then be used later on when they want to go for pregnancy to achieve pregnancy. So if somebody has cryopreserved the sperm and then later on wants to undergo pregnancy, we can use this cryopreserved sperm to undergo IUI and achieve pregnancy. Those steps involved in IUI are simple: ovarian stimulation, either with oral agents or gonadotropins, or a combination of oral and gonadotropins. The aim is to achieve, say, 2 to 3 or 2 to 4 follicles. Monitoring of the follicular growth, endometrial development, follicular vascularity, endometrial vascularity is important. Timing of the insemination depending on the size of follicle, the endometrial thickness, the follicular blood flow pattern or the follicular Dopplers, and the peak systolic velocity of the follicle, the perifollicular Doppler flow or the blood flow has to be considered while timing the insemination. Basically, the timing of the trigger is important, and the trigger would be HCG. If the patient is hyperstimulated, you can think of using triptorelin acetate, but most common trigger which is used is HCG because it is a surrogate of LH and it results into LH surge and ovulation. So timing of the trigger is important, and then according to the trigger you can time the insemination also. Normally, a single IUI is done 36 hours after the trigger. If you are planning to do a double IUI, the first IUI is 12 to 24 hours after the trigger, and the second IUI is around 48 hours after the trigger or after confirmation of the ovulation. Semen preparation is to be done before insemination, and the semen preparation is by semen wash, which can be done by a swim up technique or the density gradient method. The most commonly used is the swim up method. And then the IUI procedure, that is inseminating the washed spermatozoa in the uterus under asepsis, and in difficult cases you can use a ultrasonography guidance, and then luteal phase support is done. So these are the steps involved in IUI cycle. Now, if this couple still does not conceive after 3 cycles of IUI, then the couple should be advised to undergo IVF or ICSI treatment. So we are continuing with the same case. Married for 3 years, primary infertility for 2 years, all the evaluation done, nothing you can say abnormality was found. It was an unexplained infertility. Gave ovulation induction with timed intercourse for 4 cycles, did not work. We started with IUI. Gave her 3 cycles of IUI with gonadotropins. She was ovulating. IUI was done properly, but still she could not conceive. Then the next best treatment option for her is IVF or ICSI treatment. Now, in IVF or ICSI treatment, you have various protocols, and the most commonly used is the GnRH antagonist protocol to form multiple eggs. So, what is IVF or ICSI? That we'll see in short. So, we are covering various modalities of managing infertility in this same case. So we have seen what is timed intercourse. We have seen in short what is IUI, what are the indications of IUI. Let us see what is IVF or ICSI treatment or in vitro fertilization. We know the world's first IVF baby, Louis Brown, was born on 25th July 1978, and this historical work was done by Dr. Steptoe and Dr. Edwards, and it has been almost more than 41 years since then, and more than 85 lakh IVF babies have been born worldwide now. So basically, the mother of Louis Brown had both her fallopian tubes blocked, and that is why scientists then thought if both the fallopian tubes are blocked and they are non-functional, how will the gametes unite naturally? How will the wife's egg and husband's sperm unite if the fallopian tubes itself are totally blocked and non-functional? And that is why they then thought that why not we make the gametes unite artificially in laboratory in a proper environment, so that the embryos which are formed after union of gamete can be deposited back into the uterus to achieve pregnancy. And this is how IVF or in vitro fertilization came into being, or this technique of IVF was discovered. Now this same technique or this same funda of unification of the gametes outside, in laboratory, in vitro, in proper environment, can be used for various other indications and various other reasons. We'll see those reasons also. So this technique of IVF of 1978 was later modified in 1991-92, and ICSI came into being, or intracytoplasmic sperm injection, that is injecting each good mature egg directly with one good sperm. You can see this ICSI being done live in the laboratory under the inverted microscope. This is around 400 times magnification. Here you can see a mature egg. You come to know that the egg is mature by this polar body which is extruded at 12 o'clock. So in ICSI, what is done is under microscope, we hold the egg with the holding pipette on at 9 o'clock. You can see the holding pipette holding the egg, and from 3 o'clock, an injecting pipette will inject one good mature sperm directly into the egg to unify each good egg with one good sperm. And when one good egg is unified, or you can say fused with one good sperm, embryos will be formed. These embryos can then be reposited back into the uterus to achieve pregnancy. These embryos are usually cultured for 3 to 5 days outside in the laboratory in proper environment. And those embryos which grow very well for 5 days, form good blastocysts, are reposited back into the uterus to achieve pregnancy. Here again you can see from 3 o'clock an injecting pipette injecting the mature sperm directly into the nucleus of the egg. Here you can see the sperm being released. So this is how ICSI is done. Now let us see the indications and the way or the steps involved. The indications, or we'll see later. First, let us look at the steps involved. Steps are similar which we saw, that is ovulation induction, that is controlled ovarian hyperstimulation, use of gonadotropins to form multiple eggs. Why multiple eggs? Because we want multiple embryos. Why do we want multiple embryos? Because we want multiple good embryos, and these multiple good embryos will help us to achieve multiple pregnancies, or will help us to achieve a higher success for the couple. So control ovarian hyperstimulation is done with gonadotropins. Multiple eggs are formed. On an average, a standard IVF cycle will form at least 12 to 14 good eggs, and these eggs will be retrieved outside transvaginally by sonography guidance. By a 17-18 gauge needle, these eggs would be aspirated from the ovary, and these aspirated eggs would be then collected, and they would be fused with, each good egg would be fused with one good sperm. Here you can see after giving gonadotropins, multiple eggs have formed in the ovary, and these eggs from both the ovaries will be aspirated out. So each good egg, so here you can see under the transvaginal sonography guidance, with the transvaginal probe having a guide. Through the guide comes a 17-18 gauge needle. The other end of the needle is attached to the aspiration pump, and a suction of around 120 mm Hg is receptive to accept the embryos. These embryos will go and stick to the endometrial lining and start dividing, growing to give a healthy pregnancy. This is how IVF for ICSI is done. Now let us see the indications of IVF for ICSI. The indications of IVF for ICSI, the indication with which we started the discussion was failure of 3 IUI cycles. Sorry. So any patient any couple who has had 3 or more IVI cycles failed, the best way out is going for ICSI. Now, other indications can be male factor indications like moderate to severe oligospermia, moderate to severe asthenozoospermia, moderate to severe teratozoospermia, obstructive azoospermia. See, if there is moderate to severe oligoasthenoteratozoospermia, then the amount of motile good functional sperm is such low that it becomes difficult to achieve pregnancy with natural or IUI. And that is why ICSI comes into being, because we are going to fuse one good egg with one good sperm. So if I have 14 good eggs, I will require only 14 good sperms. Obstructive azoospermia. See, what is happening in obstructive azoospermia is basically the semen is not having sperm, but the testes are functional and the testes are having sperm. So we can retrieve testicular sperm outside, what is known as testicular sperm extraction, simultaneously retrieve good eggs from the ovary, fuse the egg and the sperm outside to form good embryos, and deposit the good embryos back into the uterus to achieve pregnancy. The testicular sperms which we extract are less in quantity, less in motility. They have to be fused with the egg directly to achieve pregnancy or embryos. So obstructive azoospermia or patients with history of vasectomy, testicular sperm extraction with ICSI is the only way out. Patients with retrograde ejaculation, ejaculatory dysfunction can again be helped with ICSI. Those females who are having tubal blockages, so we saw mother of Louis Brown had tubal blockage, and that is why IVF was discovered. Patients with severe PCOS not responding to usual treatment, patient with endometriosis, adenomyosis, patients with 3 or 4 IUI cycle failure, patients with premature ovarian aging, ovarian failure, postmenopausal females wanting pregnancy. So any female who is now finished with her eggs and then wants her pregnancy, those females who have achieved menopause and then want to achieve pregnancy, then the only way out is donor egg IVF cycle. Post-tubectomy, post-ligation patients. So many patients or couples come to us, they had pregnancies, they had 1 or 2 kids or maybe 3 kids, got the female or male sterilization done, and now the kids are no more because of accident, because of illness, because of disease, or they have remarried and thus then again want a pregnancy. So any pregnancy which is to be done after tubal sterilization, after vasectomy, after tubectomy, then the best way out is ICSI. Unexplained infertility not responding to usual treatment, then IVF or ICSI is the best way out. Certain patients with recurrent pregnancy loss, especially those patients with recurrent pregnancy loss, we saw a very good case in our first lecture of recurrent pregnancy loss also. That patient had secondary infertility with recurrent pregnancy losses, with there was translocation in the husband, and there was variation on the 21 chromosome of the wife, and thus they conceived after doing pre-genetic testing. So patients with recurrent pregnancy loss would benefit from pre-genetic testing, or those who are having genetic factors like translocation, inversion, Robertsonian translocation, they those couples who have had several recurrent pregnancy losses, those who want to ensure that the embryo which is being kept is genetically normal, they can benefit by doing ICSI with pre-genetic testing. Again, certain couples wanting pre-genetic testing for genetic disorders, familial disorders, familial diseases, various genetic familial diseases, various genetic disorders like thalassemia, sickle cell anemia, Duchenne muscular dystrophy, spinal muscular atrophy, epidermolysis bullosa, all these various genetic disorders. If basically we can know the gene of the affected parents, then we can ensure that the embryo which we are repositing back into the uterus is healthy and does not carry the defective gene, what is known as pre-genetic disease diagnosis. So various genetic disorders, we can use pre-genetic diagnosis and thus help the couple to achieve a genetically healthy baby. Similarly, those couples who are wanting to plan pregnancy after the age of 35, we know after the age of 35, the chances of Down syndrome, the chances of having a genetically abnormal baby is going to increase. So they can ensure by having pre-genetic testing that the embryo which they are keeping is chromosomally normal, is genetically euploid, and thus achieve a healthy pregnancy. Serodiscordant couples with HIV, again, you as treating physicians must have seen that nobody is dying of HIV nowadays because the medicines are so good. The response to medicines is very nice. Most of them who take proper treatment are having a negligible or undetectable viral load, and these couples then want to have pregnancy, and many of them would require help in achieving pregnancy, and ART can be the best way out. So we have looked at ovulation induction, IUI, IVF, ICSI, and the indications and process for all of these. Now let us look at one more interesting case. Again, this couple is married for 3 years, primary infertility for 3 years. She came with her mother-in-law. Cycles are regular. Her initial investigations were all normal. Her HSG was normal. And she received 2 cycles of ovulation induction by a nearby doctor. And have we missed anything in this case? So anything which we have missed in this case for evaluation? So yes, we have missed the semen analysis. So husband was an IT professional. He hardly used to come with the wife to see the doctor. And so semen analysis was left. And when semen analysis was done, it was found that husband is azoospermic. So as Dr. Ramesh has rightly highlighted, always evaluate the male partner simultaneously with the female partner. And the report of azoospermia has come. So what next? Is he azoospermic? So no. Single report of semen labeling azoospermia is not correct. We have to reconfirm. So we have to reconfirm. We have to centrifuge the sample, look for presence of sperm in the pellet. Many times, one drop of semen on the macular chamber, you might not see sperm, but once you centrifuge the semen, the pellet might have few sperm, what is known as cryptozoospermia. So we have to rule out cryptozoospermia, and we have to instruct the husband properly with proper instruction and repeat a semen analysis after 2 to 3 weeks. So while giving him instruction, we have to tell him that he has to maintain an abstinence of 2 to 3 days while giving sample next time. The sample has to be collected in the laboratory with proper instruction, with wide mouth container, sterile container, and the first part of the ejaculate has the maximum sperm. So that has not to be missed. And even if the repeat sample is suggestive of azoospermia, then only we can confirm a diagnosis of azoospermia. So now the husband is azoospermic. How to proceed? How to evaluate a azoospermic male? So the next important thing to do is evaluation of the azoospermic male. And while evaluation of an azoospermic male, the first important thing to do is a good scrotal examination. In a warm room, a good scrotal examination will more or less help you to tell whether it is primary testicular failure or it is obstructive azoospermia, or it is testicular failure versus azoospermia, that is versus obstructive azoospermia. That is what we want to find out. So a good scrotal examination along with certain blood tests for the husband, his FSH, testosterone, estradiol, and if required karyotype and Y chromosome microdeletion. So these are the evaluation which will require in an azoospermic male. Once we do this evaluation, then we can differentiate whether it is a obstructive azoospermia or it is testicular, you can say hypofunction, or testicular dysfunction, or testicular failure. So basically, obstructive azoospermia male will have normal sized testes with good turgid consistency of the testes. His FSH would be normal, his testosterone would be normal, his karyotype would be normal, and many times you may not be able to feel the vas. So it is obstructive azoospermia. While those with non-obstructive azoospermia will have small flabby testes, the vas deferens may be palpable, FSH would be high, normal or above normal. Testosterone would be normal. Karyotype would be normal. So again, the diagnosis of non-obstructive azoospermia would be made. So why we want to differentiate? Because we can prognosticate and give the overall chances to the couple. What are the chances of retrieving sperm from the testes? So this is important for prognostication. Now, treatment-wise, testicular sperm extraction or what is known as micro-TSA would be the gold standard treatment. After retrieving testicular sperm, they would be fused with wife's egg. By the process of ICSI, embryos would be formed and embryos would be reposited back to achieve pregnancy. If both the testes, even after doing bilateral micro-TSA or bilateral microscopic testicular sperm extraction, if you're not able to get even a single sperm, then donor sperm is the only way out. Again, for those couples who are absolutely not affording, they cannot afford ICSI or testicular sperm extraction, they can directly think of going for donor sperm. Now, let us move to our third case. Mrs. Lakshmi, 45-year-old housewife, married for 24 years. Tubal ligation was done 15 years back, and then she lost her only son in a road traffic accident 6 months back. So now she wants a pregnancy, irregular menses since 1 year. Her AMH is 0.01, so she's almost achieved menopause, you can say. And age is also 45 years. So how to proceed? So menopausal females with very low AMH, with premature ovarian failure or premature ovarian aging, or those who have achieved basically menopause or a premature menopause, if they want to achieve pregnancy, then as I said prior, egg donation IVF technique or the oocyte donation IVF technique is the only best way out. So we basically will have to take a medically fit young donor, take her eggs, fuse with husband's sperm, form good embryos, and reposit the good embryos in the uterus of the menopausal female after starting her menses with HRT. So we'll give HRT, start the menses of the menopausal females. After 2 to 3 months of starting of regular menses, reposited back the good embryos to achieve healthy pregnancy. Let's move towards our penultimate case. 33-year-old housewife, married for 8 years. She was an overseas patient from Yemen with premature ovarian aging, with cycles, and has had weight treatment for 15 years. AMH was 0.07, antral follicle count is just 0 to 1. Wife had abnormal karyotype. Her sonography showed focal adenomyosis with thin endometrium. Husband semen analysis was okay. Husband was HbS-Ag positive. So here you can see the reports of the couple. The wife on the left hand side, the husband on the right hand side. Wife's karyotype you can see here 46XX, 9QH plus, 15PS plus, 21PS plus. So there were various, you can say variations, karyotypic variations on chromosome 9, 15 and 21. And her AMH was 0.07, so it was premature ovarian aging, almost going into premature ovarian failure. And being from Yemen, she was absolutely no for egg donation. She wanted to have pregnancy only with self eggs. So with multiple problems, she came to us. So we had to use all the possible advanced IVF techniques for her. So let us look at various advancements in IVF and ICSI which have happened over the last 40 years, which has helped to increase the success of IVF. So the advanced treatment options of IVF for ICSI, one is the sperm sorting techniques. That is, we can sort the sperm which are having the best head and neck, which is having the best motility. Or you can morphologically also select the sperm by high magnification, from 400 times magnification in ICSI to 6,000 times magnification in IMSI. Or you can use sperm sorting techniques, as I said, microfluidic sperm sorting technique or magnetic sperm sorting techniques. we have blastocyst culture, that is when embryos are formed. First day, as I said prior also, embryo would be 2 cells, second day it would be 4 cells, third day it would be 8 cells. If I keep on culturing and growing the embryos for 5 to 6 days, on 5th day the embryo would form a blastocyst, which are said to be the robust embryos, the best embryos to give healthy pregnancy. So the embryo which is growing very well for 5 days, it has shown its robustness to give a good pregnancy. They are supposed to be, you can say, better embryos to give a better pregnancy. So to from you can say keeping less robust and more embryos, the world has now moved towards keeping more robust and less embryos, so that we achieve 1 or 2 healthy pregnancies and avoid multiple pregnancies as far as possible. So the overall the world standard now is to keep 1 genetically normal good blastocyst embryo at a time. Then laser assisted hatching, that is to help the embryo implant. We do laser assisted hatching. We soften the shell of the embryo from one side. Here you can see live under the inverted microscope. This is a day 5 blastocyst, and the outer cover, each embryo will have an outer covering. Here you can see the outer covering of this blastocyst is thick. So before repositing back this embryo into the uterus, we will thin out the outer shell of the embryo. So less energy of the embryo would be required to come out of this shell, and more energy would be left with the embryo to give healthy pregnancy. So the chances of implantation would increase. So patients who have, due to culture conditions, thick zona, thick outer covering or hard, here you can see the laser being done on the outer covering, and the thinning of the outer covering has happened. So this is known as laser assisted hatching. It helps in improving the implantation, especially in patients with previous IVF failure, patients who are having thick outer zona or hard zona. Due to culture condition, there is hardening of zona. Many times due to freezing, there is hardening of zona, and thus laser assisted hatching would help these couples to achieve better pregnancy. Pre-genetic testing or embryo biopsy to look whether the embryo is genetically normal or not. So pre-genetic, here you can see a blastocyst embryo. After doing laser, few cells of these embryos are sucked out, and then using laser, these cells are detached from the blastocyst. Now these cells would be cultured in genetic laboratory. This culture would be then exposed to various genetic tests to understand whether the embryo from which these cells came is a genetically normal embryo or not. And so genetically normal embryo can then be reposited back into the uterus. Here you can see the embryo biopsy being done, and these cells detached from the blastocyst. So these cells would then be cultured to understand whether the embryo from which these cells have been retrieved is genetically normal embryo or not. Here you can see few cells which have been taken out. So this is known as embryo biopsy, followed by pre-genetic testing. So if you keep a genetically healthy embryo, then the chances of achieving pregnancy are going to be much, much higher. Cryopreservation or vitrification, we can freeze the sperm, we can freeze the oocyte, freeze the embryos, freeze the ovarian tissue, and cryopreservation or vitrification is one such technique which has changed the way IVF was done in the last 1.5 decades. So it is one of the most, you can say, revolutionizing change in IVF, because you can freeze the extra embryos and use them for a later pregnancy. You can freeze the embryos because the uterus is not ready to achieve the pregnancy. You can freeze the gametes, the sperm and the oocyte, if the person has not completed his family but wants to undergo chemoradiation for any cancer treatment. You can freeze the eggs because due to social egg freezing, because especially the female is not wanting to have marriage or childbirth or pregnancy before the age of 35 or 40. So due to career, due to education, if the female are not going to delay their marriages or childbearing, then they can freeze their eggs, what is known as social egg freezing. So those females in whose family there is previous history of premature ovarian failure, females with family history of BRCA mutations, BRCA carrier females, they can freeze their eggs. So, and as I said, embryos can be vitrified for next IVF cycle or pregnancy. Then we have the advancement of closed working IVF chamber. And Indira IVF was one of the first to bring these advancements to India, these closed working chamber to India. We were first to import them from Australia and start using them in 2011. So they would give the same environment to the egg and the sperm as they should give in the mother's womb. Similar oxygen saturation, similar temperature, similar carbon dioxide and humidity. Instead of fusing the eggs and the sperm in an outside open environment where the outside temperature, outside pollution would affect the egg and the sperm and the embryo formation, closed working chamber would give better embryos and thus a better success. Then we have advancements of benchtop incubators, embryoscope. So n number of advancements have taken place in the IVF ICSI field, which has helped to increase the success. So RI witness is, or electronic witness system, is one of an important advancement where all the gametes and the embryos can be electronically barcoded, or there is a, you can say, RIFD attached to it, and thus any human error, any mix up, or any you can say manual error, there is no place of any mix up with this. So it is better than the manual human double witness technique. So right from changes in the instrumentation to changes in the you can say techniques, and various advancements have happened in the IVF ICSI to increase the success. So we had to use all these techniques, technology in this patient. We used ovarian rejuvenation with platelet-rich plasma therapy with stem cell, followed by minimal stimulation, accumulation, vitrification strategy with ICSI in closed working chamber, and blastocyst culture, PGTA, that is pre-genetic testing with laser-assisted hatching. So this couple who had come to us from Yemen with very low AMH, with wife having karyotypic abnormalities, and overall multiple small other problems like husband having HbS-Ag positive, adenomyosis, premature ovarian aging. So we had to use all these advanced techniques. We had to do double stimulation, dual stimulation. We accumulated her eggs and embryos twice, checked her embryos genetically. We got one genetically normal embryo, and we achieved a successful pregnancy in her. So these are certain challenging cases where we need to use all the best techniques to achieve a healthy pregnancy. So basically, again, one more case, 44-year-old IT professional, married. This is the last case we would discuss, and maybe then we would take some questions. Married for 5 years, IT professional. She was 44-year-old, overseas patient from Japan. AMH was just 0.31, antral follicle count was 4, diffuse adenomyosis, thin endometrium, poor ovarian reserve, husband having asthenoteratozoospermia. These were her reports. She already had 3 IVF cycles before coming to us, and all 3 were in Pune. So her husband and her were working with an IT company in Pune. And again, these Japanese females, they don't want to go for donor egg. So even at a higher age of 44 years and a very low AMH and low ovarian reserve, they were willing for self eggs only. Here also you can see in the history, here it is clearly written, willing for self eggs only. These were her investigations. And again, we had to use various advanced techniques, including ICSI with closed working chamber, pre-genetic testing, because her age was 44. We had to reposit back a genetically healthy embryo only, blastocyst culture, laser-assisted hatching, microfluidics for sperm sorting because the motility and morphology was on lower side, and accumulate the eggs and the embryos. We got one genetically normal embryo, and so this was her stimulation. You can see a minimal stimulation strategy, low dose stimulation, accumulation of eggs. We got only 2 eggs in our first stimulation, We again did a repeat stimulation and then a transfer. And this was her 16 weeks sonography when she was 16 weeks pregnant. And she flew back and delivered to in Japan. This is her video giving her comments and her overall treatment, you can say, feedback. So my take home message today would be proper evaluation of a couple before starting treatment is must. If you are doing ovulation induction, then a baseline scan is must. We should always try to document ovulation in our ovulation induction cycle or in our IUI cycles. After 3 to 4 IUI cycles, IVF or ICSI is the best way out. Laparoscopic ovarian drilling has to be done very judiciously in very selected patients in severe PCOS patient not responding to gonadotropins only. So because I have seen that there is rampant and indiscriminate use of laparoscopic ovarian drilling. It is not for all patients with PCOS. It is only for selected group, especially those who are not wanting to go for IVF or ICSI and still want to try with conventional, you can say, natural or IUI cycles. IVF is not the last treatment option. It depends on the cause of infertility. So it is not that all infertile patients have to undergo ovulation induction first and then IUI, and if not, then only IVF. It depends on the cause of infertility, as was highlighted in a lecture with evaluation of an infertile couple. Proper evaluation is important because most of our couples will give us a proper cause of infertility, and according to the cause, if we do a proper treatment, if she is married for 1 year only but she knows that both her fallopian tubes are bad, blocked, she has had history of abdominal cocks, she has history of genital cocks, then there is no point waiting for other treatments or other modalities. IVF is going to be the only way, best way out. Maybe she is married for just 6 months. So it depends on the cause of infertility. Thank you all for your patient listening. I have tried to be as short and as practical as possible, and that is why I shifted to this case-based discussion rather than the traditional theoretical discussion. Thank
yes,
you.
sir, it was very interesting. So with the case-based discussion, everyone must have appreciated, and it was made interesting also. So every time we had questions, oh, what will happen next, like, you know. So it was a very excellent lecture by you. So A to Z. So I think we have completed almost all the points. So now I think we will go to sir, you want to say something?
Any questions if you have, or any participant want to ask any question, maybe you can allow them by raising their hands.
Yeah, but they cannot raise a hand here. We can't see their hand. They will write a question. Very nice and informative. Dr. Rashmi Dharaskar has said. And there are other this thing also. They are also very nice and excellent lectures, sir. Thanks for precise info on dealing with infertile couple. So all good remarks. One question somebody has written, sir, role of PRP and stem cell in IVF.
So basically, basically we have two challenging situations in IVF for infertility. One is thin endometrium, and second is premature ovarian aging or premature ovarian failure. And in these both situations, one can, to certain extent, use platelet-rich plasma and stem cell in selected patients, and basically it is not magical. It will not make a patient who is almost reaching her menopause to give you tens of eggs, but to certain extent it might help, especially in thin endometrium. Platelet-rich plasma therapy, there have been many studies now. It does help to increase the vascularity, increase the receptivity, especially if you are using hematological stem cells. Then homologous hematogenic stem cells, which have been separated by doing hematopheresis, and then by doing blood pheresis, if we separate the CD4 tag hematopoietic stem cells and then inject it transfemorally via the uterine arteries by catheterizing the uterine arteries into the spiral arterioles, then it has been conclusively shown that this thin, bald, atrophic endometrium can definitely increase in size. And this was a very good, you can say, trial, which was one of the important lectures in the European Society of Human Reproduction ISHRE, you can say, annual conference 4 years before, which I had also attended. And then they had subsequently done larger studies to clearly show that if we reposit hematopoietic stem cells via the transfemoral route, then it can be very good for thin, bald, atrophic endometrium or severe Asherman syndrome, where even repeated histoscopic adhesiolysis is not giving good endometrium. So for thin endometrium, platelet-rich plasma therapy, for thin endometrium, stem cell therapy is getting, you can say, having role, and there are more and more papers which are coming up to show the role of these two. In coming back to premature ovarian aging or ovarian failure, there platelet-rich plasma therapy or stem cell therapy is still not established, still it is under research and it is still empirical. And they're using other techniques like in vitro ovarian activation, laparoscopic in vitro ovarian activation is being now tried, wherein basically we remove chunks of the atrophic failed ovary. What happens is when ovary is removed and a part of the ovarian chunk is removed, and these ovarian chunks are fragmented in vitro, and they are activated with certain activators, and they are reposited, or you can say transplanted back under the fallopian tube or in the mesosalpinx. The hippo signals which are coming from the hypothalamus and the pituitary, so the hypothalamo-pituitary ovarian axis gets disturbed, and that is why the menopausal effect on these ovaries is removed, and these ovaries then start responding to, these ovarian chunks start responding to gonadotropins to certain extent and have shown to give follicle formation. So this is one of the new research underway or going on and still not established, but these are certain, you can say, recent advances which will come in patients with premature ovarian aging or failure. Another thing is basically the oocytes of patients with very low AMH, they can be externally fed with extra mitochondria. See, low AMH patients have few follicles, and these follicles do not give good embryos because they are left with less energy. The energy producing, you can say, powerhouse of these cells are less. Mitochondria content of these follicles is less. So if we can externally infuse mitochondria by various techniques, these follicles can give good embryos. So this is again one research which is underway, still not established for routine practice, but these are certain frontiers where new things or new developments are going to occur.
So one more question. Please explain about uterine
Uterine transplant. So basically, if there is absence of uterus or the uterus is totally dysfunctional, there are two ways out. Either go for surrogacy, use someone else's uterus, or do a uterine transplant. One has to understand that doing uterine transplant involves two major surgeries, one for the recipient and second for the donor. So both donor and the recipient undergo a major surgery each. Second thing, the recipient has to be on the anti-rejection medicines throughout till her delivery, and at the time of delivery, it has to be the uterus has to be removed. It has to be obstetric hysterectomy because we cannot keep her lifelong on anti-rejection medicines. Once her childbearing is complete, the uterus has to be removed. Now, considering the cost involved, considering these two major surgeries involved, considering that after transplant she will be on prolonged anti-rejection medicines, it becomes difficult, or you can say cost versus benefit ratio definitely tilts easier for surrogacy. So it is very easy if somebody from the family itself is willing to carry the baby and after delivery give back. But of course, the pleasure of carrying the baby by her own would be there with uterine transplant. But then looking at the hardships through which the person has to undergo, and we all know our very own Dr. Shailesh Puntambekar sir is, you can say, world's pioneer in uterine transplant surgery. Again, 2-3 feedbacks which I have got is, though the uterus is transplanted, it becomes very difficult to reposit a good embryo at the right place in such transplanted uterus. So doing IVF for such patients and then repositing a good embryo in this transplanted uterus is quite difficult, and so the success still remains quite low.
Okay. Yes, sir.
Thank you. Thank you.
Yes, sir. One more question. This embryo, one of the Dr. Balani had come here in the courtroom. So he was asking how many days you can keep this embryo? What procedure is done? Means freezing means what temperature and everything.
So freezing means basically it is vitrification nowadays for the embryo. What is known as, more or less known as, dry freezing. So the concept is to remove all the water of these cells at a time and make them go directly to -197 degrees centigrade. So from 37 degrees centigrade, these cells and these embryos are directly taken as fast as possible to -197 degrees centigrade by the use of liquid nitrogen. So there are certain cryoprotectants. These cryoprotectants protect the cells, and basically water from these cells is removed and they are taken to -197 degrees centigrade and they are freezed in liquid nitrogen. Freezing of embryos, freezing of sperm can be done for n number of decades and for centuries. Practically, world literature, if you see, then people have achieved healthy pregnancy after 20-22 years of embryo freezing. I myself have done several hundreds of cases after 6 to 7 years of embryo freezing successfully. So n number of years you can freeze the sperm, eggs and the embryos. The best thing to freeze, or the best retrieval rates, is with the sperm. Second is the embryo, and third is the oocyte. Yes sir आले होते प्रश्न विचारायला. चांगलं आहे. Yes sir, yes.
सुनील इंगळे प्रश्न विचारायला आले.
Yes sir, yes, please.
नाही सर,
हाय म्हणायला आलोय सर, and thank you very much for a very excellent talk on IVF. Thank you, sir.
Yes, sir.
Thank you sir, thank you for the opportunity to
two more
interact.
questions. Sir, what are the causes if premature menopause?
The causes of premature menopause basically can be varied. It can be multifactorial, and see, the number of eggs each female is born with is very different. That is why you will see that one female is having menopause at the age of 55, while other is having at 45, and while third is having at 40, and some have at 30 itself. The number of eggs they have got from nature itself is going to be different. If some individual is unfortunate to have less eggs, she will have a premature menopause. But other than this, there are other reasons of premature menopause, and the most important which I find in practice are genetic abnormalities or chromosomal variations, like Turner mosaic, like inversions in various chromosome 1 and 9. And there can be basically variations in chromosome 1, 9, 21, which can cause premature menopause. Other than the genetic factors, autoimmune factors also is a very important cause. Thyroid autoimmunity, various autoimmune diseases like SLE, Sjogren's syndrome are also known to give rise to premature menopause. because these autoantibody itself destroy the ovaries, and that is why the premature menopause. Then various surgeries on the ovaries like endometriosis, ovarian cyst, if they are operated upon, operating both the ovaries might itself cause premature menopause. So these are the various reasons of premature menopause which we see.
So one more question. If someone wants to postpone pregnancy, what age do you recommend she freeze her eggs? That you had just answered.
So
Depends.
Usually what we say is at the age of 30, 32, check your ovarian reserve. At the age of 30 or 32, check your ovarian reserve. And then if you have a borderline reserve or a lower reserves, think of egg freezing. If the ovarian reserve is very good, then by the time of 32 or 34, it is better to freeze the. So younger the freezing, much more would be the eggs and more would be the success. But somewhere before 35 would be best. But never is the late. We have frozen eggs and achieved pregnancy at the age of 38, 39, 40 also. So if a female knows that she is not going to marry till a certain age, then around anything between 30 to 35, she should check her reserve and start to think about egg freezing.
One more question. Can you please explain how to motivate the couple if one of the partner lost hope for having baby? Counselor.
So basically that is detailed counseling. And counseling not only medically but also with a proper counselor. So that is why it is mandatory for all IVF centers to have a proper counselor. And the recent ART bill, you must have seen that proper counseling is given legal importance now. So of course, many couples who come to us get distressed, depressed because of repeated failures. And basically what I have seen as a medical practitioner, trying to scientifically tell them about the various causes, making them aware of various techniques and technology, and making them, in the sense, educating them also empowers them to take proper decision and alleviates their fear to take proper treatment. Many times it is fear which causes distress, and these couples then run away from proper scientific treatment. So, of course, counseling is very important.
Yes, sir. Thank you very much, sir. So you answered all the queries, and it was a very enthusiastic and very explanatory session. So I think everyone has got Dr. Gaikwad, sir. Again, thank you very much, both of you. So thank you for a very enthusiastic seminar.
Thank you, Lumkur. Thank you, Lumkur, sir.
Dr. Padma Iyer, madam is there. Dr. Meenakshi Deshpande.
Both of us are listening from the boardroom. Sir, thank you very much for always supporting IMA Pune's academic activities.
Yes.
And it will be done in next year's Dr. Meenakshi Deshpande's tenure also.
Yes, definitely.
She's a president.
My secretary, both of the secretaries have taken a lot of pains to make this seminar very successful.
Especially, sir, Dr. Sunil Ingre.
Sunil Ingre.
Yes.
So in his busy schedule, he has arranged everything nicely.
Thank
the
you,
rest
well
of
done.
the work we are doing,
Well done,
so
yes.
that is okay. So thank you very much. Once again, sir, this is a bouquet for you and token of thanks.
Thank you, sir. Thank you.
Yeah. And IMA Pune. So you can visit one day IMA Pune, both of you, and
Yes,
we can
yes,
visit Pune, and it will be a great pleasure. Thank you very much.
Definitely. Thank you.
So tomorrow again, the session is there for all the delegates. You can join 5 minutes before. So it will be on proctology, as said. So thank you very much. Thank you very much, and I think I thank all delegates also and our speakers also. Really, it was a really enthusiastic lecture. Nice. Thank you.
Thank you, IMA Pune, and thank you all the delegates for this interaction. Thanks a lot.
There are almost 200 people. 200. Yes, sir. Thank you. Piyush?
Yes, ma'am.
Yes. चालेल जाता
Okay, करतो.